Good morning, everyone, and thank you for coming to my grand rounds. I'm Simon Su, one of the adult nephrologists here at the university. Some of you may remember that 5 years ago, my first grand rounds as a fellow was also on fractures. So it would appear that I, much like a snake eating its own tail, am back at it again. Time I'm talking about a study that we recently did, manuscripts written, and we're hoping to submit soon on risk factors for fractures and chronic kidney disease, specifically in the CRIC study population. And I have no disclosures. So I'm saying that there are two parts to this talk, really to signal where the halfway point is, but really this is otherwise going to be fairly classic, where I'll take you from the beginning of our study all the way to the end. So the first half will be background, methods, and results. And then part two will be the discussion, which is where I try to place our findings in the broader context of existing literature and try to draw some conclusions. Part one. Most, if not all of us, are probably aware that fracture rates in chronic kidney disease in general are higher than in the general population. And this is true of non-dialysis CKD patients on dialysis and patients after a kidney transplant. No single study has really examined fracture rates across the full spectrum of kidney function, so CKD, dialysis, and transplant. But this figure was put together based on data from 3 separate studies. And the gist here is that, again, compared to the general population, which are these black diamonds, that those with CKD and dialysis are at higher fracture rates. And this really contributes to substantial morbidity, mortality, and economic cost, more so than those with normal kidney function. And so this was a study of more than 300,000 inpatient hospitalizations just for hip fractures in 2010, using a nationwide database. And so you have the 3 columns: normal kidney function, non-dialysis required CKD, and ESRD. And you can basically see that CKD and ESRD folks had higher mortality, at least equivalent to higher hospitalization length of stay, higher hospitalization costs. They were less likely to be discharged home, and those with chronic kidney disease were more likely to discharge to a nursing home. So we think that patients with CKD have a higher fracture risk because they have both traditional risk factors that are established in the general population and also kidney-related risk factors. So things like lower eGFR, proteinuria, metabolic acidosis, and of course, disordered mineral metabolism. But studies of these risk factors have really focused mostly on the dialysis population or have assessed few risk factors beyond just eGFR itself. And whether or not these traditional risk factors in the general population hold true in CKD populations is also relatively unexplored. And so my goal here was really to understand or try to understand patient characteristics that are associated with fractures in chronic kidney disease to hopefully better assess fracture risk and develop preventive strategies. Most of you are likely familiar with the CRIC cohort, but just real briefly, this was a cohort study that was established in 2003 with the goal of identifying risk factors for CKD progression and cardiovascular disease. In total, you had 3,939 adults aged 21 to 74, with a broad range of eGFR recruited from these 7 US communities. And some of the main exclusion criteria are if you're currently or formerly on dialysis, had a prior kidney transplantation, or New York Heart Association class 3 and 4 heart failure. Most of the exposures and covariates in the study were measured in the entire CRIC study population at the baseline exam. So things that you would expect, sociodemographic characteristics, comorbid conditions, medications, and also a whole host of serum and urine studies. I'll mention here that eGFR and 24-hour urine protein excretion, among some other variables, were remeasured annually. And this is important because we do a type of analysis called time update analysis for these 2 exposures that I'll talk about later. The only exposures that weren't measured in everyone were vitamin D measurements, which were done in a subset of participants, roughly half. And these 3 measures are 25-hydroxy vitamin D, 125-D. And something many of you may have heard me talk about in the past, the vitamin D metabolite ratio, which real briefly is a more novel measure of vitamin D status, and lower VDMR has been associated with increased fracture risk in non-CKD populations at high risk of fracture. So the outcomes are fairly straightforward. It's just a composite of first hip or vertebral fracture. These are two of the three most common sites of fracture and most strongly associated with mortality compared with other locations, so that's why they were chosen. Twice a year, every CRIC study participant were interviewed and asked to report hospitalizations, and research staff would collect records. And so the diagnoses, these outcomes were extracted from diagnosis codes from these inpatient stays. We did use a validated algorithm published by Wright and colleagues here, citations in the bottom right, that showed a 95% or higher positive predictive value for hip and vertebral fracture. Leila Zelnick, who's a senior author on this paper, did all of the analysis. So I hesitate to say that it was straightforward because there are some kinks that made it a little bit complicated. For the purposes of this talk and for the audience here, the analysis is straightforward. It's just Cox regression modeling variables that you might expect. So things like age, race, ethnicity, sex, comorbid conditions, and also relevant medications. So supplemental and dietary calcium and vitamin D, bisphosphonate use, estrogen-containing meds, steroids, and of course, EGFR and proteinuria. I mentioned earlier that EGFR and proteinuria were also analyzed as something called time-updated exposures. Some of you may be familiar with this, but to get everyone on the same page, I thought I'd take a brief detour to explain what this is. So in traditional Cox analysis, an exposure risk factor is measured at baseline, and then you can relate it to an outcome over the duration of follow-up. And the hazard ratio that is reported really relates to the entire study follow-up period and reflects a long-term association with your outcome. This is probably something that we're all familiar with seeing. But some risk factors may vary over time, and so if you have serial measurements of that risk factor, you can use it in a time-updated Cox model to examine short-term associations with an outcome. And so really in time-updated analysis, the follow-up time for each participant is kind of divided into these separate time windows. So for example, in this study, we measured EGFR and proteinuria repeatedly each year. And so what you get is a separate Cox analysis that's carried out at the beginning of each time window. And what you end up getting is reporting a hazard ratio that's really a weighted average of each one of these window-specific hazard ratios. And so there are two main reasons that we assess time-updated EGFR and proteinuria. Number one, we can assess short-term associations between these exposures and fractures, short-term being the 1-year period. And secondly, because some people, as time goes on, your EGFR will get reduced and some people end up on dialysis or get kidney transplant. It would allow us to compare incidence rates of fractures across the full spectrum of kidney function, which is something that hasn't been done before. All right, so going back to the results. I want to say that this type of study really lends itself well to tables, so there are a lot of tables. But rest assured, I'll walk you through all of them and I'll summarize the results at the end. So just to give you a handle on the baseline characteristics of the CRIC study cohort, relatively youngish population at recruitment, mean age being 58, good representation of female sex and non-white race or ethnicity. As you can expect, many have hypertension and diabetes. A few folks on bisphosphonates, about 3% at baseline, 4% on estrogen-containing meds, 10% on steroids. Mean GFR at the recruitment was 44, mean bicarb 25. Jumping down to the bottom, PTH, mean PTH is median PTH 54, kind of higher limit of normal here. So this is the first of many tables, and all of the tables from here on out will have the same 3 columns, hoping to make it easy for you all to read. So the first column here is the number at risk, and in parentheses, the number of events. So for example, in the entire 3,939, we saw a total of 106 hip or spine fractures over 11 years of follow-up. Second column is just the incidence rates of fractures. And the last column is the adjusted relative risk or hazard ratio, adjusted for the variables that I showed earlier in the statistics analysis page. So as you might expect, age per decade higher was associated with higher fracture risk, so almost twice as high. There were no differences by sex. Non-Hispanic Black race was a protective factor against fracture, and this is consistent with what we see in the general population. Diabetes status, those with diabetes, almost twice as high risk compared with those without diabetes. Also significant with steroid use, greater steroid use associated with higher fracture risk. And BMI, so per 5 kilograms per meter squared lower, you had about a 30% higher risk of fracture. This is the same table, continued examining some other exposures. So physical activity per 10 met per week lower. It's about running a 10-minute mile, so not associated with increased fracture risk. We looked at metabolic acidosis a couple of ways, so bicarbonate categorically and also continuously, and did not find an association between serum bicarbonate and fracture risk. And finally, getting to some of the kidney measures. So eGFR, we also look categorically and continuously as well. The incidence rates are in the direction that you would expect, kind of inversely associated. So as eGFR declines, you have a higher incidence. Hazard ratios also in the direction that you would expect, although in this baseline analysis, this was not statistically significant. And looking at proteinuria here, so if you had a baseline proteinuria of 1.5 grams or higher, you had at least twice as high risk of fracture compared with folks with no proteinuria at baseline. So these are the results of time-updated kidney measures and fractures. So this is eGFR, and what we find is per 10 points lower, that there is a 20% higher risk of fracture, and this is excluding people who progress to dialysis or kidney transplant, thinking that they might be just a little bit different. And next, we looked across the entire spectrum of kidney function by categories. And what you see is the incidence rates of fractures are, again, in the direction that you would expect, with people who progress to transplant or requiring dialysis having the highest incidence of fractures. Again, hazard ratios in the direction that you would expect, and kidney failure and dialysis are the highest risk of fracture. Proteinuria, the main gist here is that estimates are similar as to when you used baseline proteinuria for analysis, but the results are not statistically significant. So this is something called a generalized additive model of time-updated eGFR, and basically it just allows you to visualize associations of continuous eGFR with the risk of fracture. We're currently in the process of formalizing this analysis, but basically I'm using the eyeball test. You can see that at about an eGFR below approximately 40 is really when the risk of fracture starts to increase. All right, we're getting to the end. This is the last table here. So associations of CKD, MBD, biomarkers, and fractures. This part specifically looks at the 3 vitamin D measures that I mentioned earlier. And the main take home here is that none of these results were statistically significant, although all of the hazard ratios were in the direction of what you would expect. So per 1 standard deviation lower of each one of these measures, you an estimate that's suggestive of higher fracture risk. And we may not have had enough power to detect these associations simply because we measured these vitamin D measures in just half the great population. These are the remaining CKD MBD biomarkers that we tested. So PTH, we used a threshold of 57, which is the upper limit of our assay's normal. And so if you had PTH above normal, you had about a 71% higher risk of fracture. That was statistically significant. And these are the other biomarkers we looked at. So FGF23, serum calcium, serum phosphate, and urine calcium and phos excretion. None of these were statistically significantly associated with fracture risk. All right, so we've made it to the halfway point, and now I'm going to try to put all of this in context of the existing literature. But we talked about a lot, so I'm going to do a quick summary. So with regard to kidney function and proteinuria, so we found that lower time-updated eGFR and baseline proteinuria were associated with higher fracture risk, and that this risk was greatest in those who progressed to kidney failure. These are the patient characteristics that we found were significantly associated with fractures, so PTH above the normal range, older age, non-Black race, diabetes, lower BMI, and steroid use, and some pertinent negatives, so lower vitamin D status and other measures of mineral metabolism, metabolic acidosis, sex, and physical activity. So other studies have shown that CKD in general is a risk factor for fractures, but the novelty of the study is really being the first to test associations of time-updated kidney measures with fracture risk. As I mentioned, this really allowed us to do two things that haven't been reported before. One is allowed us to directly compare the incidence rates of fractures across the full spectrum of kidney disease and show that, yes, as your eGFR declines, as you get to dialysis, as you get kidney transplant, that your fracture risk increases. And number two, it allowed us to assess short-term associations of kidney measures with fracture risk, and we can draw a few conclusions. One, low eGFR, even in the short term, which is a 1-year period, may really influence bone strength. The second thing is that we found that baseline proteinuria, but not time updated, was associated with fracture risk. And I can kind of think of two reasons, at least, why this might be the case. So either proteinuria is indeed more harmful over many, many years than in the short term, or that its association with fracture is mediated by worsening eGFR. What I mean by this is in time-updated analysis of proteinuria, we also adjusted for time-updated eGFR that was measured at the beginning of each time window. And so in doing so, you kind of drop information that eGFR at enrollment was higher and may have worsened over time. And so this phenomenon may explain why time-updated proteinuria was not significantly associated with fractures. So moving on to biomarkers of CKD and BD, including PTH, most studies have been in kidney failure and much less in non-dialysis CKD before this one. So just a brief timeline, the last international guideline on optimal PTH concentration in non-dialysis CKD was in 2017, and KDIGO at the time recommended, and I'm paraphrasing here, to consider PTH lowering therapies for persistently elevated PTH. And they said this was based on grade 2C evidence, so in words, it's very weak and low quality. Since then, there's a 2019 study that showed that higher PTH is associated with fracture risk. And so this is something that's consistent with what we've shown. The only difference here is in the 2019 study, they showed that there was an increased fracture risk really at any PTH greater than 0, whereas we found that this was only the case at PTH above the normal range. Two other quick points. I mentioned that the estimates for vitamin D measures were in the direction that we would have expected, but the power might have been limited, so it was not statistically significant. And number two, whether or not PTH lowering therapies, which include vitamin D, really reduce fractures in CKD is unclear because there have been limited trials. Some trials have tested activated vitamin D and CKD on bone mineral density, but in general, they've been small, thought to be at high risk of bias, and have produced mixed results. So next, I want to talk about these 3 modifiable risk factors, so diabetes, steroid use, and low BMI. There are known risk factors in the general population, but few large-scale studies have assessed them, whether they're associated with fractures and chronic kidney disease. And even among those that have, many have used diagnosis codes to ascertain CKD status and lack direct measurements, like eGFR and proteinuria. And so they couldn't adjust for CKD severity, and so confounding has certainly had been a main limitation of existing literature. So there are a few mechanisms whereby diabetes is thought to increase fracture risks. So direct skeletal effects by advanced glycation end products, increased fall risk, likely as a result of retinopathy and neuropathy, and even diabetic kidney disease itself. There have been 3 observational studies in total prior to this one in populations with diabetes. 2 showed that DKD status was associated with higher fracture risk and 1 didn't. But as I mentioned, diabetic kidney disease status for all 3 studies were ascertained via diagnosis codes alone. And so our study here really adds a little bit more precision to existing literature. So steroid use broadly inhibits bone formation and stimulates bone resorption. To my knowledge, there's only been 1 previous observational study showing higher fracture risk regardless of steroid dose. And this is the case even at doses of 5 milligrams per day. But the main limitation of this study is that population was screened based on just a diagnosis code for glomerular disease, and they didn't have EGFR measurements. So, you don't know if those on steroids had lower EGFR proteinuria to begin with. So that was kind of a confounding factor. And so we kind of add to existing literature again by offering more precision. Low BMI is associated with low bone density and also muscle weakness. Our study is consistent with a study by Kim and colleagues showing adults with CKD who remain at a low BMI had higher fracture risk compared with normal BMI over about 8 years of follow-up. Worth noticing here is an observational analysis from the Credence trial. That's the canagliflozin trial that showed that BMI was not associated with higher fracture risk. But I think that this is because the Credence population is a little bit different. They are exclusively people with diabetic kidney disease and only had mild CKD, so stage 2 to 3. And so BMI may be a little bit different in this population compared with our study and the study by Kim. So we are wrapping it up. The one pertinent negative that I think is worth discussing is metabolic acidosis, which was kind of surprising that we didn't find associations with fractures in our study. So the general gist is that in chronic acidosis, the body's systemic buffering systems get overwhelmed. And so bone formation becomes suppressed and bone resorption is increased. So this leads to net efflux of calcium and other proton buffers from bone to really buffer this acid. And this is thought to reduce bone strength and potentially contribute to fractures. And I'll just say that our results are in contrast with one other observational study that looked at bicarbonate in over 50,000 people, stage 3 to 5 CKD, and showed that this low bicarb was associated with higher fracture risk. There's also a whole host of experimental studies linking metabolic acidosis with surrogate outcomes like lower bone mineral density and higher markers of bone turnover. And so the last thing that I'll mention here ultimately is that there's limited trial data that exist. So 2 randomized trials of alkali therapy in CKD has not shown that they've been effective in improving bone mineral density or things like physical function, surrogate measures of fracture. No trials have used fractures as a clinical endpoint, and so I really think that whether or not reversing metabolic acidosis improves fracture risk is something the jury's still out, basically. Strengths and limitations. The strengths, a lot of these I've spoken about before, but it's really the comprehensive nature of the study when it comes to assessing these risk factors, a comprehensive measurements of biomarkers of CKD MBD, and we use gold standard methods for measuring some of the exposures, such as 24-hour urine collections for protein, calcium, and phosphorus excretion, and also mass spectrometry for vitamin D metabolites. These limitations, there are a couple. So of course, this is an observational study, and so confounding is always potentially there. Number 2, multiple testing. So we had in total 19 exposures, and so potential false positives is a limitation. And lastly, we relied on inpatient diagnosis codes for fractures. So even though we used a validated algorithm with very high positive predictive value, we probably will have missed some spine fractures in particular because most of them are subclinical and occur. So our incidence rates may actually be lower than real incidence rates. So in summary, we found that lower EGFR, proteinuria, elevated PTH are kidney-related risk factors that are associated with higher fracture risk in chronic kidney disease. Diabetes, steroid use, and lower BMI are modifiable traditional risk factors that are established in the general population, but likely remain important for fracture prevention in CKD. It's kind of where we go from here. I think future studies are needed to develop or improve upon existing risk prediction tools for CKD. So in the center here is the FRAX calculator some of you may have used. And the long and short of it is that it works pretty well up until about CKD 3B, and not very well, or I should say less well in patients on dialysis. And so newer risk prediction tools will be helpful. And trials really are ultimately needed to confirm whether risk factor modifying therapies reduce fracture risk in this population. I want to acknowledge my primary research mentor, Ian, as well as my mentoring team and co-authors on this paper, and also offer thanks to former research and clinical mentors, confidants that have been with me throughout my journey. So my first rounds as a formal faculty member, I wouldn't be here without all of your support. And thank you for your time, and I'll take questions.
Thank you, Dr. Su. Questions for Simon?
Does the proteinuria cause loss of vitamin D binding protein, and that's why you get fractures? I mean, is that the primary mechanism? And did you also look at the correlation between proteinuria and vitamin D?
I did not look at the correlation between proteinuria and vitamin D, but that is one of the main mechanisms of all, you're right, is that heavy proteinuria, you lose vitamin D binding protein, which of course most of the 85% of vitamin D metabolites are bound to.
Yoshio?
Simon, beautiful slides and a very nice presentation. So I'm a little curious, as I guess vertebral fractures and hip fractures are obviously extraordinarily morbid conditions, but your event rate, at least in CRIC, was pretty low, right? I mean, you had, what, 6 events per 1,000 person years in your dialysis population, which, kind of translates into like about 600 events per year for the entire US dialysis population. And I'm just kind of wondering whether there's an opportunity to kind of expand a little bit and look at other potentially, I guess, functionally limiting fractures, like functional limitations, I guess, in this population would seem potentially an interesting avenue of, investigation, given the relatively low event rate, probably because of competing risk.
Yeah, you make some great points, Yoshio. So thanks for the suggestion, first of all. And number two, so our event rates are in general lower than have been previously reported in CKD populations. And it might be that those in CRIC are healthier than other CKD populations, or as I mentioned, we're using diagnosis codes and we'll have missed a handful of fractures in the outpatient setting. So that could be another reason.
Simon, I'm wondering, you showed a lot of associations, some surprising, some a little that cause you to question. I'm kind of inviting you to theorize. Is there kind of a big picture shift in how you think about this CKD bone mineral metabolism in terms of mechanism? Is there something that all this work has changed in your mind about how you understand it?
Yeah, this is an excellent question. So in my mind, I think there's no doubt that CKD-MBD affects bone. And I was really hoping, so this is one of the first studies that really assessed comprehensively all of those measures. And all we found was that higher PTH, which I think is a questionable biomarker, is associated with higher fracture risk. So there's something that we're missing, and something that I've talked about is we need a better marker of what's going on at the bone level. Unfortunately, bone biopsy is kind of gold standard, and there's nothing to quite match that at the moment. And so I think better non-invasive ways of assessing fracture risk or what's happening at the bone level are still needed.
Thank you. Someone should probably do a trial on whether PTH is a good marker for treatment as well, if anyone's interested out there.
Already on it.
Oh, great. Thank you. Thank you again, Simon.